Welcome to Fertility Queen podcast, and today we're lucky to be joined by fertility specialist and obstetrician Dr. Vicki Nott. Well, welcome Vicki to Fertility Queen podcast.
Thank you, Lynn.
Thanks for joining us today.
It's a pleasure.
And Vicki, I'm just going to ask, what made you want to be a fertility specialist?
Well, it was something I was interested in all along. Many years ago, my favourite book was Brave New World by Aldous Huxley, and it was written in the 30s, I believe, and he described growing babies in jars and the conditions you needed to grow the baby. So the ones that grew in the nice sunshine and got the good nutrients grew better, and the ones that were in the dark and got alcohol didn't grow so well. And I remember thinking, that's amazing. And really, he was predicting IVF, wasn't he?
Yeah.
And I found that fascinating. And when I was at university, and we did a rotation to the Royal Women's Hospital. Again, it was lovely looking after people having their babies and with their gynecological situations, but the fertility side was always very interesting to me.
It is fascinating, isn't it?
It is.
Yeah. And it sort of fits into what you're doing as well. So you deliver babies as well.
I do. And so obviously that's a very special pleasure when you've helped someone to get pregnant and then you see them in early pregnancy and you can give them the good news and show them their little baby on scan, which is a really special moment, and then look after them during their pregnancy and then deliver their baby. And of course sometimes many people have more than one baby, so you look after the help them establish their whole family over the course of a couple of years. And that's a very special journey for both of us.
Yeah, so you've probably delivered families now, wouldn't you?
Absolutely.
Yeah.
The largest family I've delivered is one of my lovely patients who had 6 babies.
Wow.
And that was fabulous.
Yeah. And sisters and brothers come along to you as well?
Very much so. And I've had 3 sets of identical twin sisters who've had their babies. And sometimes someone will come along because her brother and his wife had a baby with me.
That's so rewarding.
It
You must
is.
love your job.
Yes, very much so.
And so for a person starting to think, okay, I'm going to start having a family, what would you say they need to do and how should they prepare for pregnancy?
Unless there's a pressing age issue, I think best to just chill for a bit and check out some of the things that you need to do to prepare for a pregnancy, maybe even before you go off your contraception. And probably the number one thing to do is to be taking your folate supplement, because we know that taking folate halves your chance of certain birth defects, and it's really only effective if you're taking it before you even become pregnant, at least a month, but ideally 3 months. So even if you're just thinking about having a baby, starting a folate supplement, and any pharmacist knows what's the appropriate folate supplement to take. One with iodine is good. So if someone already has a great diet or is already on another multivitamin, they could just take the ifolate supplement. Otherwise, a general women's health or pre-pregnancy supplement that includes both iodine and folate. So that's the really essential thing. And then there are many things that a woman can do that are going to increase her chances of a successful pregnancy. And there's many websites, including my own, that people could look at for a list, or they could go and see their GP or come along and have a pre-pregnancy consultation with a fertility or obstetrician specialist as well. So the next specific thing they should probably look at is an assessment of their vaccination status. Make sure that they are immune to measles, mumps, rubella and chicken pox, because those things can be vaccinated against. You can't have the vaccination during pregnancy, and if you are unlucky enough to catch one of those diseases during pregnancy, it could harm your baby, cause a birth defect or even a miscarriage. So again, something really simple you can do while you're still using contraception. You just get a blood test with the GP, and if you're not immune to those things, then you get a vaccination for them.
Such a simple thing to do. What about the flu vax and pregnancy?
So we recommend the flu vax every year as soon as the flu season is announced and the new vaccine is announced. And certainly that's one of the questions I ask people at their very first visit in pregnancy. Have you had your flu vaccine this year? And if they haven't, I offer them one because I keep it in my vaccine fridge at work. We know that catching flu in pregnancy can be associated with a really severe maternal illness and secondary pneumonias. Pregnant women who catch the flu are more likely to end up in intensive care, and there have been deaths. And it is also suggested that flu may be associated with stillbirth.
Wow.
So definitely want to have your flu vax every year. The other vaccine is for whooping cough. That one's actually best given after 20 weeks in pregnancy. So people don't need to rush off and get that one. It doesn't hurt if they've had it, but I'm still going to get them to have another one after 20 weeks in their pregnancy because it gives their baby some protection in the first months after the baby is born until it starts its own vaccinations. Whooping cough is increasing again. It used to be quite a rare disease.
And what about family members? Should they get their whooping cough done
Yes,
before
so they could
visit
have
the baby?
Good suggestion. They can have their vaccine at any point. Best if it's well before the baby is born. So usually when I'm reminding the mum at her next visit after 20 weeks, I suggest that all family members who haven't had a vaccination within 5 years get one as soon as possible.
Very interesting. And what about the coronavirus? Does that affect pregnancy?
The good news is coronavirus does not seem to specifically affect pregnancy. It doesn't seem to cause fertility problems. It doesn't seem to cause miscarriages or stillbirth. And pregnant women who get coronavirus don't seem to be any more sick than non-pregnant women.
Yeah.
So you still wouldn't want to catch it, of course, and particularly in late pregnancy when a woman's lungs are a bit squashed by her big tummy from her baby, because, of course, a rare number of younger people who get coronavirus are going to be really seriously ill. And if you were pregnant and had reduced lung capacity in late pregnancy, that could impair the ability of your treating team to help you. So in that scenario, that would not be good. There have been a number of women in the UK who had coronavirus in pregnancy and had very severe outcomes. They were all women who were very large, obese, or smoked. So it does seem that if you've got other medical disorders and you get coronavirus, you are going to be worse off. So that's, of course, important.
And what about weight loss and getting pregnant?
Yes. So depending on a woman's age, of course, age is such a factor with fertility that I wouldn't suggest someone puts a pregnancy off for more than 3 months if they are in their later 30s. But otherwise, if someone is carrying a bit too much weight, if they are able to lose some weight, that will significantly help them. So it can help, of course, with simply becoming pregnant. We do know that being very overweight is an increased risk factor for both miscarriage and congenital abnormalities, and it increases every risk of pregnancy, in particular diabetes in pregnancy and high blood pressure in pregnancy. There's also an increased risk of caesarean if someone is overweight, and I'm afraid also of stillbirth. So losing weight is probably one of the major things a woman can do to help increase her chances of a healthy pregnancy. And it's been proven that even just a 10% weight loss, of course, weight loss is a very challenging issue in our community in general. And sometimes the thought of knowing you need to lose 20 or 30 kilos is just too much to face. But if someone puts in mind just 10%, that can be a more manageable end point for them. Dieting is completely safe. So is fasting if that's what someone is doing to achieve their weight loss. And that's completely safe to do while you're trying to conceive. And particularly if someone's BMI is over 30, it's actually safe to continue with your weight loss program in pregnancy. The increased calorie requirement of pregnancy is actually very low, absolutely no need to eat for two. In the first 16 weeks or so, it's only 200 calories a day, like one biscuit.
Right.
So you definitely don't need to eat for two. And in the later parts of pregnancy, the calorie requirement does go up, but still not by a lot. So if someone's carrying a little extra, they really don't need to eat more.
And that's important to know, because I know a lot of patients think that they need to eat for two.
Absolutely not. So as I say, if their BMI is over 30, it's safe to try and lose weight or aim for zero weight gain or minimal weight gain. If someone puts on 6 kilos or less in their pregnancy, then they've actually inherently lost some weight. And so, again, if their BMI is in the higher end, that's completely safe to do.
How much weight do most people put on?
Average is 14 kilos. That's being looked at now. So that's what is average, but is that ideal? And many people are now suggesting that maybe aiming for 8 to 10 is better. It may not be possible for everyone. I've definitely got people where I know they're not overeating and yet they do gain a lot of weight. Some people will gain 25 or 30 kilos. Those people, it often tends to be fluid and goes on at the end, and it will come off quite quickly as well. But yes, 14 is average.
And what about preeclampsia and pregnancy? Why does that occur?
Pre-eclampsia is a disease that only occurs in pregnancy, and it's characterised by high blood pressure and organ dysfunction. And the organ dysfunction might be a person's kidneys, their liver, their placenta, and thus their baby, or their brain even. And what we generally see with preeclampsia is someone will get high blood pressure. They'll often have a lot of swelling, a lot of protein in their urine, and sometimes the baby's not growing so well. And if preeclampsia is left unchecked and untreated, it can even lead to eclampsia, which is epileptic seizures, which are very dangerous for the mother and baby. The other major problem of preeclampsia, if a woman has very high blood pressure, is that she can actually have a stroke.
Wow.
And so very serious. The only treatment once you have preeclampsia is delivery of your baby. So if someone is in late pregnancy, it's not such a big deal. You can be induced or have a cesarean and have blood pressure medication and close watching and, of course, a great outcome. But if preeclampsia occurs early, particularly between 24 and 28 weeks, in most cases there's still no specific treatment. Sometimes we might manage to hang on a week or two, but it may well end in an extremely premature birth, and that is a major cause of disability and impaired neurological development in babies. So we really don't want that early onset preeclampsia in particular.
And how can you lower your risk of getting preeclampsia?
Well, there's obviously some amazing new evidence with aspirin therapy started before 15 weeks. It's been absolutely well proven that taking 150 milligrams or more of aspirin at night from before 15 weeks greatly reduces your risk, particularly of the early onset preeclampsia. It doesn't seem to do anything for preeclampsia that occurs at the end of pregnancy, but at least it's going to greatly reduce the early onset preeclampsia. The other thing people can do to reduce their incidence of preeclampsia comes back to what you and I were speaking about earlier, about having a pre-pregnancy check. Because if you're overweight, again, losing some weight will reduce your incidence of preeclampsia. If you have diabetes, better diabetic control will reduce your risk of preeclampsia. Checking in with your doctor, perhaps you've got an underlying disorder like a kidney problem or blood pressure that you didn't realise, or something like Antiphospholipid Syndrome. Any of those disorders will increase your chance of preeclampsia, and losing weight or getting your kidney problem under control or having your hypertension or diabetes better managed before you become pregnant, or certainly in early pregnancy, will all reduce your risk of preeclampsia.
So would you say that all patients should be on aspirin, or should they talk to their obstetrician first?
So that's a very contentious point. The good thing is that the big studies that were done showed no complications from taking aspirin at all. Now, even though we worry greatly about early onset preeclampsia, obviously most people don't get it. So you could argue that we're going to treat a lot of people with aspirin to prevent only a small number of people who are going to get the really bad early onset preeclampsia. Now, the good thing is if you decide to take the aspirin, well, it appears you have virtually no risks from that. Some people would say go on a risk factor approach where we look at your history and your weight, and do you have a family history of preeclampsia? Are you overweight? Do you already have a bit of blood pressure? In which case perhaps those women should take the aspirin. But we know that will only identify 40%. So there'll be people who've got no past history at all who will still get it. And so there is also a test you can have to see if you're high risk for preeclampsia. It's quite a good test. It involves having a blood pressure, particular type of blood pressure check and blood test at 11 weeks, combined with some additional features on your normal 13-week scan, and they're all plugged into an algorithm, and it can give a predictor for early onset preeclampsia. So if someone's really not keen on taking aspirin, they could consider doing the preeclampsia testing and then make a decision that way. I certainly had a patient this year who was only 37, very slender, low blood pressure, no past history of anything. I discussed aspirin with her, as I do with all my patients, and she didn't really want to take it if she didn't need to. So she did do the preeclampsia test, and she came up as high risk.
Wow.
So she, under the circumstances, she did decide to take the aspirin. Now, in fact, she did get early onset preeclampsia. She got it at 26 weeks, and we were able to treat her very aggressively and get to 27 weeks. And at that gestation, every day makes a difference to the baby's normal survival. So she had a caesarean section at 27 weeks, and her little boy, James, is doing very well. What we believe is if she hadn't taken the aspirin, she may have got the preeclampsia at 23 weeks, at which point there would probably have been no chance of survival for her baby. So she's very glad for the opportunity to have had that test and taken the aspirin. And she'll now take that, of course, in any pregnancy that she has, because preeclampsia can recur in subsequent pregnancies.
And do you tell the patients to stop the aspirin before delivery?
Usually we say take it till 36 weeks.
Right.
In fact, it's because we worry that aspirin is a blood thinner and perhaps there'll be an increased risk of bleeding problems, but that's never actually been seen. And even if someone has been taking their aspirin and end up having an early birth, it doesn't seem to be a problem at all with their birth or if they have a caesarean or an epidural.
That's great to know.
Yeah.
So what about miscarriage and aspirin? Does aspirin help with people with recurrent miscarriage?
Oh, so unfortunately, it doesn't seem to help a lot except for one small group of patients. So there's a nasty disorder called Antiphospholipid Syndrome, and some women will never know they've got Antiphospholipid Syndrome until they start trying for a family and they have miscarriage after miscarriage. And hopefully someone will think about it and test them for antiphospholipid syndrome early. And it's a simple blood test looking at some antibodies in the blood that seem to attack parts of your own body. And it appears that with the antibodies in antiphospholipid syndrome, they attack the way the cells of the blastocyst, their day 5 embryo, implant into the uterus, and the antiphospholipid antibodies also seem to damage somehow the lining of the uterus so that embryos don't implant perfectly. And we know that taking aspirin and heparin seems to help that subgroup of people with recurrent miscarriage. And so some people who maybe have had many miscarriages will take aspirin and the blood thinner heparin, which is an injection, and that will enable them to have a successful pregnancy. People who have recurrent miscarriages where we can find no other cause, statistically, aspirin doesn't really seem to help those people. But I wouldn't deny someone who wants to take aspirin the opportunity. I think, 10 to 15 years ago, we didn't know everything about antiphospholipid syndrome either.
Yeah.
And now we do know a lot about it. And so I feel that as years go on, we'll discover other causes of recurrent miscarriage that we currently put in the group of unexplained. So if someone said to me, look, I know I don't have antiphospholipid syndrome, but I've had 3 or more miscarriages and I'm going to take aspirin, I wouldn't discourage that.
What about IVF patients coming to see you? Do you believe they are at high risk?
Well, unfortunately, yes. And I think the statistics are now clear on that. They're at increased risk of preeclampsia. They're probably at increased risk of something not quite right with their placenta, which could affect their baby's growth. And unfortunately, again, at increased risk of stillbirth if they go to their due date or beyond. I don't want to panic people. We're still talking about small numbers of a problem. But yes, I do believe they are high risk, and I do recommend aspirin for the prevention of preeclampsia and of a small baby. And I recommend all IVF patients strongly consider having their baby around about the 39-week mark and no later, give or take a day. And for some of them, even a little earlier, depending on their personal circumstances.
And should they have a caesarean section?
That's another interesting consideration. Certainly, if they want a caesarean section, I'm going to chat through with them about the risks and benefits, and I'm not going to deny them that. I think we know that all babies are precious, but for some patients who've had IVF, it may have been a very long journey, and they've got to the very end, and sometimes the birth can be yet another major stage in that journey. So I would usually recommend that we plan a delivery date. If the patient has a strong desire for a caesarean, then I'm always going to say yes, and we will do that. If we get to that time when their baby is due and their body's just not ready to labour, then in those circumstances, I would often suggest we do a caesarean. If their body's very ready and sort of favourable for labour, we could try induction of labour. So I would always chat about that with the patient, and we would look at all their other risk factors and what's gone before.
What about their cervix? There is talk that they're at increased risk of losing their baby early from a lot of procedures on their cervix.
So when I see someone for their first ever visit, I have a checklist I go through so that I never forget things, and that's one of the things I consider. And we know that 1 or 2 procedures on your cervix should not really increase your risk of a weak cervix, but sometimes those procedures start to add up, and that could be miscarriages, embryo transfers, hysteroscopies, curettes, and certainly if someone's ever had late miscarriages, that would be a very concerning feature. So once those things seem to start to be increasing, I would talk to my patient about a number of strategies to prevent cervical weakness or cervical incompetence. And one of the strategies could be to take progesterone through their pregnancy. Now, again, that's controversial. We know that progesterone is definitely not harmful. We know that it's definitely useful if we find someone's cervix is already short at preventing miscarriage or late miscarriage or premature birth. Is it absolutely proven to prevent a weak cervix? No. But certainly what's called the NICE guidelines in England do recommend taking consideration of progesterone in pregnancy, and it's something I always do. So if I think someone is going to be at potentially increased risk, I'm going to give them the option of taking progesterone from the end of the first trimester. Obviously, many IVF patients are already on, so they could just stay on, and taking that through to 34 weeks. The second thing I'm going to suggest is that we watch their cervix on scan to check the length of their cervix, because a shortening cervix is a risk factor for losing their baby. And the final option we have is to actually stitch the cervix closed. So if someone has actually lost a baby before, between, let's say, 16 and 24 weeks, I'm going to carefully discuss that option with the patient. about the prospect of having a 13-week stitch put in their cervix to keep it completely closed. A small number of people who've had definite losses due to weak cervix might even be better considering having a permanent suture put in their cervix, which is done through keyhole surgery when they're not actually pregnant, and it stays there forever. Those patients need a caesarean.
Particularly if they've had surgery on their cervix before.
Absolutely. So that's surgery on your cervix, depending on what type, could be a major factor for a
like
weak cervix.
Cone biopsy.
A cone biopsy. Certainly a cone biopsy combined with a number of other factors would be a considerable risk. There's some treatment for early cancer of the cervix, which means people can still retain their fertility. That would be high risk, and I would definitely recommend those patients have an abdominal suture before they're even pregnant.
And what about genetic testing before you get pregnant?
So there's a couple of different kinds of genetic testing. The first kind is called reproductive carrier screening, and it is a great, if you want to consider that, it is a great thing to do before you're actually pregnant. And there's a number of companies, and what you can do is you can contact the company and they send you and your partner a cheek swab kit which you send back, and you're both tested to see whether you could be carriers of disorders that you might not even realise that could be really serious or life-threatening to your baby. The result, it does cost a couple of $100, and the results take about 3 weeks. But the advantage of doing it before you're even pregnant is that if you find you and your partner together are at risk of having a baby with one of those disorders, you can look at ways of preventing it from happening. And of course, one of those ways is IVF with pre-implantation genetic diagnosis. So you can have embryos created and at the day 5 stage, take a couple of cells off the outside of the embryo, which is not where the baby grows from, freeze the embryo whilst you're awaiting results, and have the cells checked to see if they carry that serious disorder. So I've certainly had a patient who carried a serious disorder where she had a 50% chance of bowel cancer, and she had to have all her bowel removed at a very young age, and she didn't want to give that risk to her baby. That's a dominant disorder, and so it meant any of her children would have a 50% risk of going through the same thing she did. So even though there was nothing wrong with her fertility, she had IVF so she could choose embryos that didn't carry the gene that caused the bowel cancer. And had 2 children.
Yeah, I think that's a very important thing to consider. Even though it does sound expensive, I think in the long run. Last week we picked up a patient, they were both carrying the gene for deafness, so they actually had a 50% chance of having a baby with deafness. So we've picked that up and we're going to organise for them to do PGD to test the embryo for that gene.
And of course, not everyone... some people just want the knowledge, don't they?
Yeah.
It doesn't mean that they would all necessarily go down that IVF route, but at least then they've got options. I think that's what the testing is all about.
Exactly. Well, is there anything else you'd like to tell our listeners today, Vicki?
I think just making sure you're as fit and healthy as you can possibly be when you're getting ready for your pregnancy, going for the healthiest diet you can imagine, as getting as much exercise as you can. I didn't say this before, but it's actually been proven that being fit can also reduce your risk of getting pre-eclampsia. So leading the healthiest lifestyle you can, keeping alcohol to a minimum, of course avoiding smoking, any drugs, checking any medications with your GP, and then hopefully you'll have a lovely, successful pregnancy.
And come and see you to deliver it.
That would be very nice.
Well, thank you very much, Dr. Vicki Nott, for joining us today.
Thank you, Lynn.